Welcome to The Coalition. This is a talk show dedicated to discussing health, wellness, and inspiration. I'm your host, Dr. Shani Belgrave. Hello, everyone. Thank you so much for joining The Coalition. I'm your host, Dr. Shani Belgrave. I am a bariatric and minimally invasive surgeon in Atlanta, Georgia. I'm also the founder and CEO of Oneka Bariatrics and Wellness. You can learn more about me and get connected at www.drshanibelgrave.com. I am excited to welcome to the show Dr. Holly Lofton. Dr. Holly Lofton is an esteemed obesity medicine specialist at NYU Langone, who is here to share her expertise on GLP-1. Dr. Holly Lofton, thank you so much for joining the coalition.
Thanks, Dr. Shani. Thanks for having me. I'm looking forward to this conversation.
Yes, I'm super excited that you were here. Not a day goes by where someone doesn't say to me, what's the real deal with the GLP-1s? And so I'm excited to have an obesity medicine expert on the show. Dr. Lofton, please get us started by telling us a little bit about who you are and what you do.
Thank you. I'm a board certified obesity medicine specialist. So that means I do everything for weight management, but not surgery like you do. So thank you for doing surgery. That means I offer specialized diets, all medications for weight management, and help people with their weight-related conditions such as diabetes, blood pressure, etc. And I really feel that obesity is a lifelong condition that even when someone's weight is normal, it's not cured. So I do follow patients essentially for life, keeping in mind they might need different treatments at different times. I also do clinical research on many of the medications that you know on the market now, and some that are in the pipeline. So we'll talk more about that later, but I'm happy to give the real deal about GLP-1s today.
Fantastic. So let's just jump right into it. The GLP-1s, people are familiar with some of the brand names, Ozempic, Wegovy, Zepbound, Mounjaro. Can you kind of give an explanation in simple terms as to how these medications work?
So one thing that's really important to know is GLP-1, which stands for glucagon-like peptide 1, is a naturally occurring hormone. Dr. Shani, you, myself, everyone listening and watching all makes GLP-1 from our intestines every time we start eating a meal. And that GLP-1 goes to the brain and eventually tells us to stop eating. It also has some benefits that it indirectly can help with fat cells shrinking in size by making patients respond more to the insulin they make. And also it makes your stomach empty slowly so you digest the food that you eat or absorb the nutrients from that food. But those are what the GLP-1 medications do too. So in summary, they decrease appetite in the brain, make the stomach empty more slowly, and hormonally make our fat cells shrink indirectly by changing the way we process insulin. So these are all naturally occurring hormones we give back to the people in a form of medication. And there are different types, and we can go through the names. GLP-1s are used for many things other than weight loss. I'm sure people are familiar with their use for type 2 diabetes. But now, specifically Wegovy, which is the weight loss version of Ozempic, is approved to treat fatty liver disease. Zepbound, which is the weight loss version of Mounjaro, is used to treat obstructive sleep apnea. And there are many other indications or reasons people might use these beyond weight loss that are being investigated.
Well, thank you so much for providing some clarity on that. So I think that's a great segue into who should be on these medications. It seems lately from watching media that many people are on these medications and a lot of celebrities have been doing endorsements. But when someone has concerns about their weight, how do you counsel them on whether or not a GLP-1 could be the right choice for them?
Well, it's really important to know that these are FDA-approved medications, and they should be coming from a well-versed prescriber. You don't want to get them from your friend or your cousin. You don't want to get them from a source that's unknown. You want to have a conversation with the prescriber about how this may help you. But what's most important is that it's determined that you don't have any contraindications or any reason that taking it would be dangerous. So the first group of people it's not for are those who either personally or had a family history of medullary thyroid cancer. And this is a very rare condition, maybe affecting 1 out of every 15,000 Americans. But if you do have that history, these medications are not for you. The next is other GI disorders. You can have more robust conversations with your doctor about it. But if you have problems with digestion or pancreas or gallbladder issues, it's really up to your prescriber and yourself whether these are safe for you, because they might do some different things with dosing or may not prescribe it at all. So that's the first thing. Is it going to be harmful? And then most people, the answer to that is no. And the next thing is, how could it help me? So for weight, we look at body mass index, which we know is an imperfect measure for looking at someone's weight or risk of morbidity or even death, mortality. But it is a simple height-weight ratio that we use to determine who's a candidate for medications. So those who have a BMI over 30, they're candidates. Those who have a BMI 27 to less than 30, with a weight-related condition like blood pressure or heart disease, are candidates. And it's also important to know that some of the GLP-1s are indicated for our adolescent population, which means those aged 12 to 17. But right now, Zepbound or Zeppotide is indicated for those who are 18 and up, whereas Wegovy is indicated for 12 and up. So it's important to really make sure that you have those conversations with your provider to see who may be a candidate and who it's not really for.
Thank you. When we talk about side effects of the medication, some that have been talked about a lot are the GI side effects, nausea, vomiting, diarrhea, constipation. What are your thoughts on that? And would you say that the side effects tend to get better with time if people are able to stay on the medication for a period of time?
Well, one thing I will tell you, this is a conversation I have multiple times a day. I see patients for weight management, over 20 of them a day, and I'm also involved in the trials for these medications. So I've been using them before they were on the market. So I give you the answer of what was presented in the trials and then what I see clinically. So you're absolutely right. The most commonly reported side effects are gut related, because these are gut hormones we're giving back to people. In order, nausea, depending on the drug, next is constipation or loose stools. Vomiting can be a side effect. But if you look at the numbers, none of these are reported more than 50% of the time, which means most people do not have side effects that they think is worth reporting. But those who do are very vocal about it. So that's why you hear a lot about these side effects. So it's important to know that you could have mild side effects, mild nausea that is fleeting and goes away. You could have moderate nausea that lasts hours, and you can have severe nausea that leads to vomiting and you feel horrible all day. So it's important to look at the severity of the side effect, not just whether it's present or not. And depending on the drug, let's just start with nausea. At the highest dose, Wegovy's nausea is reported about 44% of the time. So not quite 50, but 44. What I see clinically is on these drugs, patients will have some nausea at some point. Whether they think it's bad enough to report, pick up the phone and call the doctor, it's not usually, but some people will have severe nausea. They have to make a phone call or send a MyChart message for. So it's about having that communication with your prescriber to determine what's serious and what's not.
What are some of the other side effects or things that can happen? Other things that people have been talking about are quote unquote Ozempic face, the concern for decreased muscle mass or sarcopenia, and also alopecia.
So one thing that we do when we talk about side effects is when you've seen as many clinical trials, there's a long list of side effects, takes over a whole page. So anything that's reported more than 1% needs to be put in the trial. So we're aware as providers what these are, but we don't usually talk about the ones that are 2% or 1%. And the things that you mentioned are more in the 1 to 3% range. I'll start with hair loss. These medications are used for weight loss, and weight loss alone, with or without medication, can cause hair loss. The body really can let go of what it considers to be non-essential tissues like hair when you're losing weight. And sometimes it has to do with how rapid the weight loss is. What's important, if I see a patient with hair loss, we make sure their nutritional status is optimized, that they're eating protein, drinking water, that they're not getting low on iron, because those nutritional deficiencies can also lead to hair loss. And then if it's severe, not treated with those type of treatments, then we may discontinue or lower the dose of the medication. And then moving on to what the next one you said with muscle loss. So there's a lot of talk about muscle loss with these medications. We know that when you lose weight, we don't only lose fat cells. Our goals are to shrink the fat cells, but that does come with some decrease in muscle composition. as well as the size of the muscle. We have to keep in mind muscle is, let's think about a bicep. It's not fully muscle tissue. There can be fat within that muscle tissue. So when you're losing weight, losing that fat makes it seem as if your muscle size is going down. But there have been definitely reports, and most people will lose about 3 pounds of muscle for every 10 pounds they lose. So that's 7 pounds of fat to 3 pounds of muscle is the usual ratio. And they've done some analysis of this, and people who are taking the GLP-1s are not losing more muscle mass than someone who's losing weight without the GLP-1s. But that being said, it's important to make sure you're eating your protein, doing your resistance training and things like that. And there was a third side effect you asked me about.
Quote unquote Ozempic face.
Ozempic face, yes. So again, these drugs cause fat loss. And when we gain weight all over, including in the face. So sometimes if someone's have a weight condition, that can appear some of the face. You have a nice baby-like face, and then we lose fat there. The skin is still there, but the fat is gone, and that can make the face look like it's sagging. We've been seeing this for a long time in our patients with bariatric surgery. Even in our office, they lose weight, and they say, now I look older because I have wrinkles, because the fat's going, I have nowhere to go. What can we do? We offer them fillers sometimes to take up that space. But it's not as if it's making you age prematurely. I will tell you that having decrease in your fat mass does decrease inflammation all over the body and can be useful for making your lifespan actually longer. And the other thing, if you think you don't like the way your body looks at any part with the medication, we can always slow it down. If we want to slow down how quickly you're losing weight, we can adjust doses and things like that.
Thank you so much for covering those areas that come up a lot. I wanted to find out the real deal about maintaining weight after cessation of the GLP-1 agonist.
Yeah. So what we're talking about here is what happens when I stop taking the medication. And as I mentioned earlier, I think you treat weight for life. So we're always looking at what is the best option for any individual at the given time. Let's start with the clinical trial. So the studies show that when patients start a GLP-1 and get up to the highest dose, average weight loss is about 20%. So that's a 200-pound person losing about 40 pounds. And they did a trial that was very sneaky. They kept some people on the drug and they lost more weight, maybe another 5%. And those who were unknowingly given a placebo or a fake drug, but continued their lifestyle recommendations, gained about 14% of that weight back. So they were left with a 6% net weight loss at over a year, at about a year and 20 weeks, year and a half, whereas those who continued the medication had sustained weight loss. The reason for this is the medications are giving you a physiologic benefit. They're decreasing appetite. They're keeping your fat cells a smaller size. They're making your stomach empty slowly so you're full with less. And when they're taken away, that's gone. Now, with our best efforts at diet and exercise, we can maintain some weight. Like I said, there's 6% net weight loss over a year and a half. But if you're hungry, which you will be after losing weight, if your fat cells can now, because they are a gland, get bigger, then weight gain tends to occur. So we do expect people to regain weight after discontinuing the medication because we're not taking it anymore. Just like if we stop a blood pressure medication, the blood pressure tends to go back up. That being said, I do give everyone who wants a trial off to see what happens, because it is possible to stop the medications and not gain weight, but we don't really have a lot of data now on how to predict who those people might be. And you'd be surprised. It's not always the one who's an ultra marathon runner and eating caloric restriction. Some people just maintain, they're 70 years old using a walker. They don't need it and they don't gain weight again. On the converse, I've seen patients do everything right, diet and exercise, and regain all of the weight. So that's individualized.
So what are your thoughts? I agree that obesity is a chronic condition and that there can be different things that we use to treat it, kind of multimodal therapy.
Yes.
What are your thoughts on the combination of bariatric surgery and weight loss medication? I'll start by saying that in my practice, I have used it preoperatively for patients above a certain BMI, because we know that beyond a certain BMI, surgical risk goes up.
Right.
And so I've used it in that way with good results. And then sometimes for patients who've had weight loss surgery, who are many years out, that are, because of the chronicity of obesity, having issues with weight regain, adding those on. But what are your thoughts on kind of the multimodal approach to obesity?
I'm really glad you brought this up, and I'm glad that we're here having this conversation together as a bariatric medicine and bariatric surgeon talking this out, because there definitely should not be an us versus them mentality when
Either
treating.
or.
Right.
Mhm.
We need to adapt to get the best result for the patient. I wholeheartedly accept what you've done in preoperative GLP-1 use as well as postoperative GLP-1 use, because this is in line with physiology. We know that if someone has a sleeve gastrectomy today at noon, that when we wake them up at 1:30 from their anesthesia, their GLP-1 level is through the roof because we've cut their stomach, and incretins, which is what GLP-1s are, those gut hormones are started to release. And that's why you wake patients up and they don't have diabetes anymore automatically before they've lost weight. That's why you wake patients up and they're really not hungry, because their natural GLP-1 is through the roof. Now, we know that over time, a year, 2 years, even 4 years, that level can start to come down that the patient's making inherently. So we give GLP-1 back in the form of a medication to continue to get weight loss or avoid weight regain for that person's health and longevity. And I've actually done some research on this. We looked at patients who had gastric bypass and they regained weight, and we gave them either, everyone had the dietitian and recommendations for exercise, but we gave some people a GLP-1 and we gave some people a placebo. No one knew what they were getting. The placebo group, who just had the lifestyle but were well supported, gained 2% of their weight back over a year. Those who had the GLP-1 in addition lost another 9% of weight. So this is physiologically helping patients get results beyond what they can with lifestyle alone. So I definitely support this. And I want to tell anyone out there dealing with weight regain after bariatric surgery to not be afraid to go back to your doctor. I find it unlikely they will chastise you, but try to find an answer for you as well, because there also could be some anatomical issues that need to be investigated. So don't avoid your bariatric surgeon if you have weight regain, but embrace it.
Thank you. Please return and see me. Well, thank you so much, Dr. Holly Lofton, for providing real expertise on what is a very salient topic. For people that have enjoyed meeting you on the coalition, what is the best way for them to get connected?
I think it would be great to look at my Instagram, which is at Dr. Holly Lofton. I'm also on Twitter, Dr. H Lofton. That's Dr. Holly Lofton. And I share some insights on trends I'm seeing with my patients and new scientific advancements. So that's a good way to get some new information.
Absolutely. Well, thank you so much, Dr. Lofton. I hope to see you on the show another time.
All right. Excited. Thank you.
Thank you. Well, everybody, thank you so much for tuning in to another impactful episode of The Coalition. I'm your host, Dr. Shani Belgrave. I am a bariatric and minimally invasive surgeon in Atlanta, Georgia. I'm also the founder and CEO of Oneka Bariatrics and Wellness. You can stay connected with me at www.drshanibelgrave.com. Very special thank you to Dr. Holly Lofton, a renowned obesity medicine expert at NYU Langone. You can get connected with Dr. Lofton on her social media. Make sure you share this episode with friends and family to raise awareness about obesity and the latest in treatment. I'll see y'all next time.